Well, that's a tough act to follow. I changed the title a little bit to indicate the top 10 things this nephrologist wishes every primary care physician knew, because I'm basing it on an article that was in the Mayo Clinic Proceedings about a year ago that indicated the top things these nephrologists wished that primary care physicians knew. And I knew Alfred would be a tough act to follow, so I tried to get somebody else to give this talk, but unfortunately he wasn't available. So, number one, a normal serum creatinine level may not be normal. Now, you've heard this from 2 of the 3 speakers already, so I will go through this fairly quickly, but the stages of CKD we've already discussed. And why is this bad? Because the further along you are in the stage of CKD, the more likely you are to die, have any kind of cardiovascular event, and have a hospitalization. So that the patients in stage 4 or 5 CKD have a 3 to 6 time number of going into death or hospitalization. Now, I'll quickly skip through some of these. One of the problems is that many of our patients don't know where they are. As you can see on this slide, the patients, and this is in 2004, so hopefully the numbers are better now, but in 2004, if you were in stage 4 CKD, only 41% of your patients were actually aware that they were in chronic kidney disease. So that their GFR was below 30, but only 41% of them knew that they were in chronic kidney disease. And why is this? Because back then, serum creatinine was our surrogate marker for kidney disease and chronic kidney disease rather than GFR. Now, since the estimated GFR has been available, you can see that the number of nephrology consults has increased. This is Ontario, this is Canada, and even in Canada, the number of referrals to nephrologists is increasing based on the estimated GFR that the primary care physicians are receiving. So you need to know the GFR. And the serum creatinine is inadequate, and I will apologize to Alfred. I've stolen some of these slides from him. There's a variability in the assay of serum creatinine, and small changes may reflect large changes in GFR, especially early in the stage of CKD. So, and you can tell that this is an old slide because Shaq was still playing for the Lakers, but do Shaq and Spike Lee have the same creatinine generation rate? Obviously not. So Shaq's serum creatinine may be 1.5, and he may have a normal GFR, whereas if Spike Lee, who I guess weighs maybe 120 pounds, if he had a GFR, serum creatinine of 1.5, his GFR would be obviously abnormal. So here's a 21-year-old woman who's got a lot of problems. She's got reflux, she's got chronic kidney disease, she's wheelchair bound, she has cardiomyopathy, and her serum creatinine is 2.7. What's her GFR? Well, based on the Cockcroft-Gault formula, 32. That's not so bad. Based on the MDRD formula, her GFR is 24, a little bit worse. But if you really do the calculations with a 24-hour urine creatinine, her GFR is 9. So serum creatinine can be a misleading marker, and even the eGFR by the formulas may be misleading, and we may actually need to do the urine testing to get their actual GFR. And I'll show you the laboratory studies of a patient that I saw within the last few weeks. This is a 58-year-old man. His serum creatinine was 1.33. He was sent to me because he has stage 3 chronic kidney disease. His GFR by the MDRD formula is 55. Lo and behold, we do the 24-hour urine test. We do a urinalysis. We do an ultrasound. His kidney function is normal, as you can see by the creatinine clearance by the 24-hour urine. He has no proteinuria. His kidney ultrasound was normal. So this man, who is my age, has no kidney disease, even though by the laboratory criteria he is defined as having stage 3. So we have to take these laboratory parameters with a little bit of grain of salt, in that the low serum creatinine may be normal, the low serum creatinine may be abnormal, and the estimated GFR may need some interpretation by you with further testing. I'll skip these except to mark in that red box the change in GFR that accompanies a change in serum creatinine can be quite significant. If a person has a normal serum creatinine of 1 and their GFR is 120, their serum creatinine goes up to 2, their GFR is 60, they've lost half their kidney function. If somebody's serum creatinine goes from 8 to 16, we would panic. That's a 50% loss of GFR. But if somebody's serum creatinine goes from 1 to 2, we don't necessarily panic, but we maybe should, because they've lost half their kidney function as well. Now, number 2, Alfred touched on this as well. Dialysis is a palliative treatment. Once you're on dialysis, that's it. You're on dialysis indefinitely, with a very small percentage of patients recovering kidney function. And this, again, dovetails with what Alfred mentioned about the initiation of dialysis at higher GFRs. Is this helpful or harmful? And this is our network. The end-stage renal disease networks are around the country, and I think there are about 18 of them, encompassing a number of states, and our state is in end-stage renal disease network number 15. Over the last 15 years, the serum creatinine at which patients started dialysis has declined from 8.2 in 1994 to 6.3 last year. Is this good or bad? I'm not sure. Because the dialysis patients all have a much higher mortality. So once you're placed on dialysis, your mortality as compared to anyone of your age group is magnified multiple times. As the incidence of the increase in GFR in patients starting dialysis is all by these patients who have higher GFRs. So that if you look at the bottom of the slide, in 1996, the average GFR starting in any age group was much lower than in 2005. So again, we're starting patients at a much earlier stage than we were 10, 15 years ago. And what are the drivers on this? Number one is too heavy a reliance on the estimated glomerular filtration rate instead of symptoms and signs of uremia. So we're starting patients on dialysis when they reach a certain number rather than by looking at the patient and making a clinical judgment. There's a general lack of understanding concerning the use of eGFR as one part of the process for determining the best time to start dialysis. And to be perfectly honest, it's easier to manage these patients when you put them on dialysis in terms of volume, anemia, and blood pressure. So there's a kind of an ease in terms of placing the patient on dialysis, and that takes the primary care physician off the hook and puts it on us. And finally, as Alfred mentioned, there are certain financial motives to start dialysis early. The US RDS, which is the US Renal Data Systems, looked at this, and actually in one of their studies in 2008, patients in the 65 to 74-year age group who started dialysis earlier had a 25% first-year mortality, whereas if the GFR was greater than 15, their mortality was increased. So that we might not be doing our patients any favors by starting them on dialysis early. Number 3 is fairly simple. There are some medications that spuriously elevate the serum creatinine level, and this actually is not reflected by any change in GFR. The most common culprits are your trimethoprim sulfamethoxazole, your ranitidine, cimetidine, and famotidine. These decrease the secretion of creatinine by the kidney. On the other hand, cefoxitin can spuriously increase the serum creatinine level by interfering with the colorimetric assay. Patients with decreased GFR or proteinuria should be evaluated for the cause. Alfred went into this in fairly good detail, and I will not go into this in much more detail, other than to say that just the fact that you have proteinuria makes your prognosis worse. You don't have to have renal failure or other problems related to the chronic kidney disease, but if you have proteinuria, your relative risk of stroke and other cardiovascular events is increased. So that is why decreasing proteinuria, in addition to slowing down the progression of kidney failure, may actually be important in terms of cardiovascular protection as well. Big issue is blockers of the renin-angiotensin system. We are very hesitant in terms of taking patients off angiotensin blockers if their serum creatinine rises or if their serum potassium rises. And we're also very hesitant about starting patients on ACEs or ARBs if their serum creatinine is elevated. If you place a patient on an ACE or an ARB, they may all have a transient increase in serum creatinine level. So an increase of 20 to 30% is acceptable as long as this stabilizes and does not continue to rise. This means that if you place a patient on an ACE or an ARB, you monitor them. You don't say, see you back in 6 months. You monitor them within the next 2 or 3 weeks, and if the creatinine has risen by 20 or 30%, you need to continue to monitor them to make sure that this is not continually rising, under which circumstance you may actually need to discontinue the medication. This article was published about 3 or 4 years ago in the New England Journal of Medicine about the efficacy and safety of benazepril in patients with advanced chronic kidney disease. And I'm sorry about the way the slide projects, but if you look at the bottom panel, the patients in group 1 had serum creatinines that were slightly abnormal, 1.5 to 3 milligrams per deciliter, and they were placed on benazepril and had a slight decline in kidney function over 36 months. The ones in the square boxes had serum creatinines of 3.1 to 5, and they were placed on benazepril. Their kidney function did decline, but at a slower rate than placebo. So that placing patients with fairly advanced chronic kidney disease on an ACE or an ARB is still doable. It's not a contraindication as long as you closely monitor the patients. That's the key. 5A is ACE and ARB combination therapy better than monotherapy? I think that was answered, but the on-target study, which was recently published within the last couple of years, looked at patients placed on ramipril or telmisartan or a combination of both. Ramipril has a lot of data, especially in the HOPE study in cardiovascular disease, and these were patients who were at high risk from cardiovascular disease. They were placed on ramipril, an ACE inhibitor, telmisartan, an ARB, and the combination. And as you can see, the patients who had the combination had a higher incidence of renal impairment and had a higher incidence of hypotensive symptoms. So that the combination of ACE and ARB probably has no place in current medicine, even as Alfred mentioned with the retraction of the COOPERATE study. Anemia in patients with CKD should be treated, but not over-treated. Anemia is a common complication of patients with chronic kidney disease. There's an increased risk of anemia as chronic kidney disease progresses, and it happens in at least 50 or 60% of patients with chronic kidney disease. The causes are multiple, the main one being erythropoietin deficiency. There are obviously other causes as well. The toxins may suppress RBC synthesis, there's shorter red cell survival, and you can see the rest. But erythropoietin deficiency is probably the major cause of decline of hematocrit as kidney function declines. And the impact of this is that the patients can have a decreased quality of life, they may have an increased morbidity and mortality, and they may have worsening cardiovascular disorders and physical and psychological impairment. In this one study published 13 years ago, the hematocrit was brought up, left ventricular mass index was brought down, indicating that as you brought the hematocrit up, and you can see from 25 to 35, the left ventricular mass index was brought down, indicating that you may improve left ventricular function or hypertrophy with improvement of anemia. And this study presented 10 years ago, again looked at anemia in patients with chronic kidney disease. And if your reference hematocrit is 33 to 36, as the hematocrit went down, your relative risk of outcomes was worse. What was interesting is that if you look to the right, as the hematocrit was higher, there was a hint that the outcomes may have been worse as well. And this generated 3 studies that have been published fairly recently. The most recent one, the TREAT study, which was published earlier this year, looking at treating the anemia of patients with chronic kidney disease and either treating them to a hemoglobin of 11 or hemoglobin of 13. And in the TREAT study, the patients were actually not treated unless their hemoglobin dropped below 9, and they received rescue treatment. So that the TREAT study was actually probably the most rigorous study in terms of the divergence of target hematocrits. I'm not sure which one of these groups I wanted to be in if I had anemia of chronic kidney disease. But I'll just go over a little bit of the 2 studies. In the CREATE study, the group 1 in the red was the higher hematocrit, and their survival was a little bit lower. And the hazard ratio for death, stroke, myocardial infarction, or heart failure was 1.3 when the hematocrit or hemoglobin was 13 versus 11. The TREAT study had similar results. The higher hematocrits had really no benefit, and in fact, there was an increased risk of stroke and thromboembolic episodes. So the take-home message from this is to treat the anemia, but not overtreat. The target right now is unclear. Certainly above 12 is not acceptable. And I think the current number is between 10 and 12, and I'm not sure that anyone has the exact correct number. Number 7, hypotonic IV fluids should only be rarely administered. Hospital-acquired hyponatremia can be lethal and has been reported to develop in up to 30% of hospitalized patients. The other thing is that hypotonic IV fluids are overused and can be dangerous. Most patients in the hospital have some disorder where arginine vasopressin or ADH is increased. They're either hypovolemic, they're hypervolemic in heart failure, they're hypotensive, or they have some other non-hemodynamic stimulus. And routine administration of hypotonic IV fluids to hospitalized patients can result in fatal hyponatremic encephalopathy. So that in the hospital setting, 0.9% saline should be the most common IV fluid used, and hypotonic fluids should only be used in patients who have actually ongoing free water losses. And the patients who are at the greatest risk for developing neurological complications secondary to hyponatremia are children, postmenopausal females, and postoperative patients. Number 8, most patients with hypertension should not be screened for secondary causes. There are estimated at least 70+ million hypertensives in the U.S., and if we screened every one of them for a secondary cause, we'd be spending a lot of money. In the primary care clinic, 95% or greater of the patients have essential hypertension and don't have secondary hypertension. Even in a referral hypertension clinic, only 9% have secondary hypertension. And the clues to the presence of secondary hypertension as to whom you should screen are here. And I think the next to bottom one is an under-recognized cause of uncontrolled hypertension, sleep apnea. And I think people who have uncontrolled hypertension, working them up for sleep apnea will probably be more productive than working them up for pheochromocytoma or hyperaldosteronism, especially when we look at Alfred's slide of the evolution of our species. In patients with recurrent stone disease, an in-depth metabolic evaluation is needed. You need stone analysis if available, serum calcium, phosphorus, electrolytes, and uric acid, as well as a 24-hour urine stone risk profile. This is fairly simple. Many of these are commercially available. The issue is to determine who is a patient who has recurrent stone formation. The person who makes a kidney stone once every 10 years probably would not benefit from this, but patients who have frequent stone formation, I think, deserve to have a metabolic workup. And Alfred saw this last year, so pardon me again, Alfred. But is vitamin D the next miracle drug, or have you joined the vitamin D bandwagon yet? I'm sure 90% of the people in this room have joined the bandwagon. Who has not? Oh, a few haven't. Well, me? Not yet. So I joined this vitamin D bandwagon. November 2008, Health News, check your vitamin D intake to avoid multiple health consequences. Low vitamin D levels are associated with depression, hip fracture, and increased risk of death. The Vitamin D Council has been very active in promoting vitamin D therapy and workup. But where did the Vitamin D Council get their money? Enough said. So vitamin D is a lipid-soluble compound, and it comes in two forms, D2 and D3. These are either coming from ultraviolet light or by dietary supplements, metabolized in the liver and the kidneys to form calcitriol, which is the active form of vitamin D. And the known benefits of vitamin D, or known actions of 125, are to increase intestinal absorption of calcium, increase PTH-mediated bone resorption, and decrease renal calcium and phosphate excretion. So these are the classical actions of vitamin D. There are some non-classical actions as well. Vitamin D may regulate cell proliferation and differentiation. It may regulate our immune function, and it may have some endocrine effects. And you can see some of the endocrine effects that have been purported to be actions of vitamin D, including insulin resistance. These are the definitions. Severe vitamin D deficiency is less than 10 nanograms per ml. Now, you're used to this, and patients are being treated routinely with levels below 30. And the risk factors, I think, are the elderly, dark pigmented skin, people who are living above the 38th parallel, especially in the winter, and you can see many of the other associations with vitamin D deficiency. And you can see the possible consequences of vitamin D deficiency. Musculoskeletal are obviously well proven. The non-skeletal, there have been studies showing that vitamin D deficiency is associated with cancer, autoimmune disease. I haven't heard about global warming yet, but I'm sure that'll come along too. But there is data that vitamin D, as your vitamin D level goes, as you develop vitamin D deficiency, your relative risk for attachment loss, for being able to walk, to have colon cancer, and to have fractures goes up, whereas your bone mineral density goes down. So that this is supportive data for people to be placed on vitamin D when they have low vitamin D levels. And also, as your vitamin D level goes down, your risk for probability of cardiovascular event goes up. Now, about 10 years ago, homocysteine was the sexy element that we were measuring. And when homocysteine was low, we were treating people with megadoses of folic acid to prevent cardiovascular disease, and that went by the wayside. The question is the low vitamin D level causative, or is it an associated factor? And I'm not sure the answer is completely in yet. This was just presented within the last 2 months by, as you can see, Dr. Joseph Muhlstein from Intermountain Medical Center Heart Institute. And the study looked at baseline and subsequent vitamin D levels in 9,000 subjects with known vitamin D deficiency, rechecked their vitamin D, then compared their subsequent rates of death. And they found that people who normalized their vitamin D levels were significantly less likely to develop cardiovascular events over 6 years. The statement at the bottom, however, says that this wasn't a randomized trial, and so we still don't have the complete answer. This was presented at the rheumatology meetings, where a rheumatologist presented a paper that vitamin D supplementation may actually up your heart risks. So I think, in my view, the question is not completely answered whether vitamin D is the new miracle drug. And as you can see, I haven't joined the bandwagon yet that most of you folks already have. Thank you. So we are available for questions. Please use the microphones because they are recording this. Step up and we'll be happy.
How much of an effect in reality does prostate disease have as an obstructive phenomena for kidney disease?
Prostate disease is still a fairly common problem with chronic kidney disease. Frequently we'll have patients come in who have had slowly progressive benign prostatic hypertrophy with slowly progressive urinary retention. They come into the emergency department, they have over a liter of urine in their bladder, their creatinine is markedly elevated, and many of these people have fixed kidney failure and may actually wind up on dialysis even though the obstruction is relieved. You hope that that's not very common with people getting routine medical care, but it's still it's not an insignificant problem. And unfortunately, if it goes on long enough, those patients have irreversible kidney failure. Yes?
Can you comment on the scenario of the hospitalized patient who comes in with an elevated creatinine from baseline and they're fluid overloaded, maybe due to heart failure or liver failure, and oftentimes they get Lasix and their creatinine continues to rise? What you do in that situation?
You punt. That's a very difficult problem. I don't know if Alfred or Chris, do you folks want to? I'm not going to answer all the questions, am I? That's a very difficult problem because many of these patients have right heart failure rather than left heart failure. They have diastolic dysfunction, which is a very difficult problem to treat. And the margin between volume overload and volume depletion, or effective volume depletion, in most patients or most persons is quite wide. But in patients with heart disease or lung disease or liver disease, that margin is very low. And the key is to diurese them to the point where they're not in pulmonary congestion, but not over-diurese them, so that a close monitoring of their volume status is really the way to go with those patients. I don't know if either of you have any other points. There's no magic answer there. Yes?
You think gastric jejunum bypass may slow down the development of diabetic nephropathy, since it makes...
What?
I don't think the epidemic. The larger answer, I think, is that the epidemic of obesity and diabetes and its complications is a public health problem. And I don't think bariatric surgery is an answer to that. I think that there's an ongoing study now to look at the effect of bariatric surgery on diabetes and diabetes outcomes. But, potentially by improving the metabolic state of the patient could decrease the eventual CKD burden. But on a population basis, it's not really much of an answer. I think
it may be our government's only indication for bariatric surgery, since everybody needs it, including me. But who's going to pay for it all? Interesting thought. I know one patient who absolutely has cured diabetes, if that ever happens. So it makes you wonder if it'd slow down the nephropathy. Thank you, Harry.
Back to the vitamin D club. Muhlstein was talking about 5,000 international units per day. That's ridiculous. But some vitamin D is good. Where should we be? 1,000 a day? Just whatever you happen to run into? Go in the sunshine every once in a while? Is there any reasonable area that's worth... Because patients ask. They want to know. So you got to have an answer. You can't just say, Senekjian says it doesn't work, and Muhlstein's way out of line. Got to have a better answer than that.
I don't think there's an answer as to the dose. The best answer today is the blood level. And there's an optimal blood level of greater than 30. The assay is fairly expensive, so that it's not a blood test that you can do every week. So I think right now there's no answer. If they're severely deficient, many people recommend giving them 50,000 units weekly till the level comes up, and then 1,000 or 2,000 units daily. But that's all, I think, speculation. There's no hard data there.
The 50,000 unit requirement, that's not in the club. Those guys are pathologic. They're a different group. Thank you.
What effect does the average dose of over-the-counter non-steroidal anti-inflammatory drugs have on CKD?
Epidemiologically, the countrywide, we really do not know. In fact, there are some people who claims that if you have normal kidney function, it probably doesn't do much of anything. The real problem is that who do you know would have have a kidney disease that is relying on prostaglandin? Let me explain that a little bit. The problem with prostaglandin is that inhibitor is that it causes vasoconstriction in essence in the kidney. So the people who relies on prostaglandins to cause vasodilation in the kidney, these are the patients, for example, who have bad congestive heart failure, unfortunately elderly, as many of us become. These are the people who rely on vasodilatory prostaglandin to maintain the kidney, the renal blood flow, and these are the patients who are susceptible to it. But epidemiologically, as you're walking around the street, do I know who is going to benefit, who is going to be suffering from non-steroidal as a kidney damage? I don't think we know at this point.
How fast can we get a patient in to have a shunt put in? If we wait till they're really in need of dialysis, what kind of a timing do we need to have?
The problem is that a fistula, we call them fistulas obviously, take at least 4 to 6 weeks to mature, and in older people with bad vessels, it even takes longer. So that you like to have the fistula put in at least 2 or 3 months before you anticipate they need dialysis. Now, when they need dialysis, it can be subjective. As we showed, the patients starting dialysis have a lower serum creatinine, but if they're in, quote, stage 4 chronic kidney disease or late stage 4 chronic kidney disease, I think those are the patients that really should have the fistula put in at that point. Any other thoughts?
A lot of Two questions. Number one is, what's an easy way to check for albumin? Do we send the specimen to the lab, or are there sticks that we can get? Most of us use the multi-stick, which only has protein. And then number two is, I am so tired of seeing patients who have had multiple CT scans with dye, they end up going to get a catheterization, and then have more dye, and they've had one 6 months ago, and it just seems like they're just being inundated with so much dye. Any way we can slow down the ERs, you go in with chest pain, you automatically get a CT scan, and they've had one 6 months ago, and it seems like no one's looking at the old tests and stuff, and the dye keeps going on and on, and just hurting these kidneys.
You really need to do a urine albumin creatinine ratio, which means you really got to send the specimen to the lab to get an analysis. Anything short of that is really not going to give you the information you need. The dipsticks are, a semi-quantitative measure of albumin with a semi-quantitative measure of creatinine isn't really going to help you very much. And if it's positive, then you've definitely got to move on to an albumin-creatinine ratio. The thing is that the test has gotten much cheaper. And in general, if you send it out, it should cost about $10. And we're trying to get away from, there's a number of problems with the test. One is that it's got 47 different names, and the other thing is that it gets reported in many different ways, sometimes milligrams per gram, sometimes micrograms per milligram, which are dimensions that nobody thinks in. So actually, my program has a laboratory working group that's working to standardize how the test is done and how it's reported. But, it doesn't cost more than about 10 self-monitoring glucose sticks. And the utility of people doing that who aren't on dialysis is really open to question. So it's relatively inexpensive. There's no really good point-of-care way of doing it right now. So you pretty much got to send it to the lab. Well, I think the issue of repeated insults is probably, and avoidance of those insults is probably a major opportunity to reduce the burden of CKD or progressive CKD. I think that's something that there's widespread interest in looking at that.
It's always a struggle for the people who have advanced CKD, say the GFR only 15, 20 mils per minute, or very close to whatever number you choose, close to dialysis, and they have some angina, for example. I won't say unstable angina. And the decision to when to sacrifice the last few nephron to go on dialysis versus take care of the heart now is a balancing act, and I think it really is an art rather than a science right now. I treasure the kidney as much as anybody else, but I would have to say that when there's a danger of infarcting the whole anterior wall of the heart, I would say go for it, and just use as little dye as possible. I think hopefully with the radiology circle, they have lots of money in the research I'm talking about, to develop better and better technology, how to do things that's either less nephrotoxic and give us the answer for different organs. An example would be gadolinium-aided MRI. We thought that was the godsend to avoid the iodine contrast toxicity. But a few years ago, then it's reported they got nephrogenic systemic fibrosis. So we got all kinds of warning about not to use gadolinium in people who have at least stage 5, perhaps stage 4 CKD. But I still have hope that the radiology world would develop better and less nephrotoxic ways of imaging different organs. But I have no great optimism that will cost us and the taxpayer any less money.
I'm interested in the high-dose phosphate preparations used for colonoscopy. You touched on that. All that stuff is poisonous. There's the ethylene glycol 1 gallon thing. That's just a gallon of seawater. Anybody knows you die if you drink seawater. And they expect you to take this stuff and live to tell about it. So someplace along the line, I've got the idea that if you have a patient on high-dose Nexium, esomeprazole, and put them through one of these things, you have to look out for significant renal failure that sneaks up. It's weeks, months later. They've forgotten all about the colonoscopy. Do you know anything about that kind of episode?
I'm not aware of any problems with Nexium and patients with chronic kidney disease. I think the phosphate was more in line with the high dose of phosphate that was given for colonoscopy preps. And those preparations are now a prescription item. They used to be over the counter, but those preparations are now a prescription item, and they're really not very commonly used. Some of the non-phosphate laxatives are used for colonoscopy preps now.
I just have a question. We do screening UAs on our physicals, and a lot of times on a young, healthy, athletic male or female, we find some proteinuria. How aggressive do we get to work that up? I mean, their labs are normal, and I don't know how aggressive to be, whether I just have them drink more and come back later.
I think the current dogma is still that if you have more than 1 gram proteinuria per day, then regardless what the GFR is, probably would be helpful to get a kidney biopsy to define the diagnosis. Obviously, try the best you can to find out the. You want to go?
Well, I'm just saying this is just on a dipstick, so I should get a 24-hour urine collection even with a dipstick. Okay, that's.
Then you need to quantitate.
Okay.
You have no idea what it is.
I mean, does running or athletics make you feel proteinuria? I mean, I see it a lot in young athletic females.
So 1 gram of proteinuria per day.
Okay.
If you assume somebody who makes 1 gram of creatinine, right?
Okay.
It's usually males maybe a little bit more than females, but we're not worrying so much about if you have 1 gram versus 1.2 gram versus 0.8 gram. It's really not that much. So assuming they have 1 gram of creatinine, you make creatinine a day. So if your ratio is 1 to 1, really, so that is really mean you have more than 1 gram per day. So in other words, if you take a random urine and the ratio of protein to creatinine is really 1 to 1, then you mostly around have 1 gram. And I don't really care, as I said, whether you have 800 milligrams or 1.2 gram. If an otherwise healthy person have 1 gram proteinuria repeatedly to be documented in the case, I think you really need to find out what is the, almost invariably, it's going to be some underlying kidney disease. There is transient proteinuria. It's more prominent in upright position, and usually in the daytime is more protein than nighttime. But we are talking about really maybe 100 milligrams in the daytime and 50 milligrams at night, or even 75 milligrams at daytime and 30 milligrams at night. We're not talking about 2 to 3 plus dipsticks. But just be aware that dipstick urine is 3, let's say it's 3 plus. They give you 300 milligrams per deciliter. Well, what exactly is how concentrated it is? I always remember a story when I was in training in UC San Diego. A guy came in for kidney biopsy and turns out to have focal glomerulosclerosis. Young, healthy guy, 25, 30-year-old. And I asked him, and turned out to have, nephrotic proteinuria, several grams a day. And I said, how did you first find out? He said, I went to a plasma center to donate blood. I said, wow, so did you end up donating? He said, yeah. I said, how did you do that? He said that, well, the dipstick it was 1 to 2 plus, and they told me to go home and drink tons and tons of water. And come back, the dipstick it was trace of 1 plus, they passed me, okay? So I think that's the concentration of the urine is really can determine it can fool you. But if you are 2 to 3 plus, and repeated dipsticks next day 2 to 3 plus, I think that it's not. I would try to not have the fever, not having menstrual period, and not heavy exercise. I try to avoid those kind of things. But otherwise, 2+, you're pretty much out of luck. I think that.
Okay. Just another quick little question. Do we have? Yes, exactly. Okay. Just a lot of the diabetics that have borderline renal function, glomerular filtration, who are basically on glucophage, do we continue safely on that, or do we pull them off?
On what?
Glucophage, metformin.
Glucophage. Well, I think I still have to go with what the PDR says. That's right. And they're quite conservative. Although, I mean, I am obviously a little bit worried when you get down to 25 mils per minute. Although I think I have to say that lactic acidosis is really not common. I think that's but I cannot go against the PDR. I mean, that's still warning. Right? But, as Harry said, that, what exactly is that GFR that you're talking about? I'm not that eager to say, wow, this is 49 mils per minute. I'm pulling you off. I'm not that.
Actually, there was just a big There was just a big meta-analysis looking at metformin and risk of lactic acidosis, and the conclusion was that it wasn't an issue, except all of the studies excluded people with kidney disease.
I have just a kind of a practical question of management of microscopic proteinuria that's difficult to get down below 30 in somebody that may be at stage 3 kidney disease. You're using an ACE or an ARB. Used to be an ACE and an ARB, maybe Tecturna or something. I'm just wondering at what point. I'm managing usually these people with 3 or 4 different antihypertensives, still not able to get the albumin below 30. Any comments? Should we be using Tecturna more? Is the study still out there? Is there other things we should be doing? I didn't notice if the combination ACE and ARB were getting a better, lower proteinuria outcome or not.
So I think the ACE and several answers to that. The ACE and ARB combination as of now, according to cooperates, retracted, on target that Harry talking about, is the major reason why is more renal insufficiency is from acute renal failure, not ESRD. Number 3, there's a large VA cooperative studies now in progress using the combination of ACE and ARB compared to monotherapy. Tecturna, basically one major study out of Europe, right? Compared to ARB alone, compared to losartan alone. Several hundred patients, not that small, but it's really one study. I think it's reasonable for diabetic patient, right? It's really the diabetic. It's reasonable to put them on. I think you can definitely not be faulted to put them on, not be faulted not to put them on. It's not really the standard of care at this point. And finally, I would mention, and then also mention the aldosterone antagonist, spironolactone. Bob Toto in Dallas has showed that adding low-dose spironolactone, 25 milligrams a day, on top of ARB is better than ARB alone in decreasing proteinuria, and I think even perhaps slightly decreasing the GFR. That was just published a few months ago. I think is it Kidney International? Okay, but it's only one small study. I think it's probably no more than about a couple hundred patients or something like that. So it's a potential. And finally, there's just something patients you cannot do anything about. All right, if they are, the proteinuria is a marker for bad kidney disease. Some people like Remuzzi, the slide I show you, believe that proteinuria actually itself is toxic to the kidney. Right? So we do the best we can to lower it. But we cannot normalize it. Many patients cannot be normalized, period. I mean, by normalized means below 30 milligrams a day. Okay, so.
If you're close to 30, you're in very good shape.
Well, some of them I cannot even get below 1 gram or 2 grams. I mean, that's just the way it is. 20 grams, right?
One last question about anemia. With the patient that has known chronic kidney disease, how far are you taking the workup for anemia? I mean, beyond getting their ferritin levels, beyond a B12?
Well, a little bit of is clinical judgment, but the CNFs won't even allow you to start it with ESA or erythropoiesis stimulating agent or EPO, unless you have the basic workup, right, the stool guaiac and even B12 folate, which is seldom negative. Seldom is abnormal, but definitely iron deficiency. I think what is attributable for chronic kidney disease, anemia, the last 15 years is much more liberal than 30 years ago. By that, what I mean is that in the past, if you have a creatinine of 2.5 or 3, and you have a hemoglobin of 11 or 10.5, people say, wow, you better work up for anything else. But now I think it's quite clear that that's relatively mild CKD can cause anemia, but perhaps even less recognized. Forget about stage 3 wimpy CKD with 55 mils per minute. Unfortunately, many of us that's a little bit elderly or have mild infection, mild inflammation, chronic inflammation, could have inflammation-induced anemia. And if this just happened, a 70-year-old guy who has eGFR of 55 mils per minute, a creatinine 1.3, and have a hemoglobin of 11, whether you attribute it to chronic kidney disease or attribute it to something else which is not easily diagnosable and treatable, I don't think it matters a whole lot, really. You can call it anemia secondary chronic kidney disease, or you can call it anemia of chronic illness. Nowadays, they believe to be perhaps a common pathway of hepcidin that's basically decreased utilization in the red cells. So I think that's perhaps the brief answer to your practical question is that there's no fixed answer, because if you plot GFR to hemoglobin, you have a huge confidence interval. Okay, so we do not do a lot of workup other than clinical judgment at the patients who have CKD, especially when the GFR is below 30 mils per minute or so.
Do you have any favorite erythropoiesis stimulant drug that you like to use in this situation?
Oh, you mean in this particular situation of not refractory or with CKD?
Just the anemia associated with chronic kidney disease.
Oh, no, I won't dare to recommend one or another other. But I think in essence, what's available in this country is really quite comparable.
Is there one that you don't have to give every week, like once a month?
Oh, I give a lot of patients monthly therapy now. I think that's, for example, well, yeah, monthly therapy is very commonly done, I would say.
Thank you.